Thank you very much for inviting me to speak here. And as Dr. Shyam Agarwal and Dr. Kaul brought out, it's great to actually be here in the physical space. And we are discussing early breast cancer. And you know that the detection of early breast cancer is impossible without the radiologist's involvement. That said, breast cancer is a field where the radiologist, the pathologist, the oncologist, and the oncosurgeon all work closely together in not only diagnosis, but also management. Screening mammography has changed the game altogether. It's imaging asymptomatic women who show no signs or symptoms of breast cancer at all, but you still image them and you image them at regular intervals. And this has led to significant reduction in breast cancer mortality, as has been brought out by multiple studies in more developed countries. Over the last 35 years, we have seen a 30% dip in breast cancer mortality, some of which is definitely due to treatment, but a lot of which is due to early diagnosis. So when we diagnose these early lesions, they are impalpable because they're either tumor in situ or stage 1 cancers, that is up to 2 centimeters. So quite often, especially if deep in the breast, they cannot be felt. So now what are we going to do with these cancers once they are diagnosed? The surgeon obviously needs to take these out, but if you can't feel them, you cannot be approximating, and you have to go in and localize them. So the radiologist comes into play here, and this enables the surgical excision of non-palpable breast lesions. For example, if you see this lesion right here, it's a, can you see the arrow? No. Okay. So you can see that lesion right there. It's a very tiny lesion, and the surgeon needs to go in and locate that. So now what we are going to do, the radiologist is going to figure out how to reach this lesion and is going to put in a wire like this or a non-wire localizer. And then the surgeon will follow this or follow the non-wire localizer and go in and get that mass or calcification, whatever the lesion is. So this removes the targeted tissue with adequate surgical margins while avoiding unnecessary and excessive surgery, because cosmesis is something that's very important to any woman with breast cancer. Whatever the age, they don't want a deformity, they don't want a missing breast, if possible. Also, in women with a large tumor burden prior to the onset of neoadjuvant chemotherapy, it's important always to clip lesions. This is a better than 5 centimeter mass. And in this, before you start neoadjuvant chemo, it is important to biopsy and then to put in a clip at the point of biopsy, also in the metastatic axillary nodes. So you see this clip here and this clip there. This is for later localization. Now, the traditional localization methods are wires. Now, wires of 2 types, typically fish hook, so named because it's, it is like the kind of hook on which we impale a fish, and we can actually think of the lesion like a fish. And the other is J wire, which has a tip like a J, and you put it into the lesion. So these are the 2 kinds of wires that we usually use. Now, what is the procedure? First of all, the radiologist is going to identify the easiest access to the lesion. So in this case, the easiest and shortest access would be from this side, because from the top, it would be a very long depth and a long surgical dissection. Everything is aimed at a shorter dissection and a smaller volume of tissue coming out. So we are going to localize and put in the wire from this side. This, of course, may not match the surgeon's desired incision line. So we are going to come to that later. So when we want to put it in from this, the side, we are actually going to compress in the opposite direction, put in the wire there, and and then adjust under vision. We have also worked out a kind of a tweak in Gangaram, where we do freehand tomolocalizations. This is a process that has been perfected by us and now presented in multiple conferences. And in this, you don't have to change the position of the patient. So in a single compression, we do the localization, And we have found across multiple patients that there's a better than 93% accuracy. So you can see there, it's a very small architectural distortion seen only on tomosynthesis, and we've got the wire straight through it. We can also put the wire under MRI guidance. You have MR compatible wires, and also under ultrasound guidance. In the lesion that I have been showing, it was visible on ultrasound, 7 mm only. This wire was put in under ultrasound guidance, and right there in the center, you can see it. This is very easy for the patient because she's lying down. You don't give her any additional radiation except for the check films. Even when you're doing a localization under ultrasound guidance, it is imperative that you go in and take check X-rays to confirm proper placement of the wire. After that comes the discussion with the surgeon. So this, we are always in touch with the surgeon on phone, on WhatsApp. We are sharing images, even though we hand images to the patient. Frequently, even before the patient has reached the OT, the images have reached the surgeon. We are going to discuss how deep from the skin it is, where the thick part of the wire is in relation to the lesion, exactly how much the diameter of dissection has to be, and if the lesion, in a hook wire localization, the most important thing is that unlike a biopsy, it doesn't have to be absolutely accurate. It has to be within a surgically dissectable margin. So even if you're 5 mm off, it doesn't matter because it's a 3D dissection. You're going to take out 2 to 3 centimeters of tissue. So 5 millimeters off doesn't matter as long as the radiologist can tell you exactly where the lesion is and where the wire is. So this is the tomo thing. Again, we say the distance from the skin, etc. We can mark the tip of the needle on the skin to prevent unnecessary dissection. And also we give us a diagram, a paper drawn diagram with the name of the patient and a similar distance from the skin, where the tip is, where the thick part is, where the lesion is, to make it very easy for the surgeon to go in and dissect. This is a sample of the kind of diagram we send out. So now after the wire is in and the surgeon has dissected, remember the process is not complete without the pathological specimen coming back to X-ray first and being imaged. We have to have a specimen radiograph for the procedure to be complete. Without that, your hook wire localization or your non-wire localization process is not complete. It has to come to radiology even before going to pathology. So this is how we take a specimen image, and you can see that the lesion is out. Now, in case we can't see it on 2D, sometimes we take a tomo of the lesion, and this is a tomosynthesis image of the specimen. So we can see the lesion very clearly, but in this one, you can see that it's close to the margin. So in this, we would advise revision of the margin. So now, how are we going to advise revision? So always the surgeon tells us where the sutures are. It's a single thread, double thread, which margin. You can see I've put this low exposed image here so that you can see the 2 sutures there. So we can say that this margin needs revision and the surgeon will go in and revise that margin. So before the pathologist is going to comment on the margin, we will comment on the visual aspect of the margin and indicate to the surgeon before closing that this margin needs revision. Then after the procedure, of course, it's over to the breast surgeon, and they're going to deal with the patient and issue final results and recommendations. Now, there can be some complications with wire localization. There can be usual interventional and surgical complications like pain at the wire site, hematoma development. There can be vasovagal syncope, which we do have once in a while, more because of anxiety and the patient is fasting, etc. The correct area may not be excised in a small percentage of patients. Ideal wire entry site, as I mentioned, is determined by the radiologist. The surgeon may want to go in at a totally different site. So this is something that is a problem with wire localizations. Wires can migrate within the breast, as we'll see. There can be a retention of foreign body. There can be a pneumothorax. And wire migration can even happen to extramammary sites. So I'm showing you a couple of complications. These are the exception and not the rule. They shouldn't put you off localizations. So in 2003, we had this 44-year-old female who came to us for a screening mammogram, and we discovered this architectural distortion with an ultrasound correlate. As you can see, there's architectural distortion there, better seen on the mag view and on ultrasound there. So we put in a wire. There's the wire being inserted and send the patient to OT. But then we waited for the specimen radiograph, and no specimen radiograph came to us. We waited, we called the OT repeatedly. Finally, we were told surgery is over long back, the patient's gone, the specimen is in pathology. This was 6 p.m. We tried to get the specimen for pathology, finally disgruntled, we packed up and went home. In 2007, the patient came back to us for a screening mammogram at 48 years of age. And what do we find but the hook of the wire still in place? Sadly, the wire had been transected outside. We hadn't seen the specimen. The wire was still in place. And then this was again localized and operated. So foreign body retention can be a complication. Another complication which happens in fatty breasts is that the wire can move. So here's a patient in which we had these calcifications, tiny calcifications. She had an invasive lobular carcinoma on the other side. So we were very suspicious of these. Biopsy was non-conclusive, so we decided to excise. And as you can see, the wire was totally in place when we did the localization. This is the deployed wire. But by the time she went to OT and the specimen came back, fortunately, the calcs were out, but the wire had moved 5 centimeters. So this can happen even with good fixation of the wire on the skin. Then another problem that happens in fatty breasts. Here's a patient who had these coarse calcifications, and on biopsy, this was ADH. So we were worried about concomitant DCIS, ductal carcinoma in situ. So we needed to localize this. And there was an ultrasound correlate, which was biopsied and found to be the ADH. So we decided to go in on ultrasound and localize this. And there's the wire going into the lesion. You can see very clearly it's there. But lo and behold, when we take the check X-ray, here is the calcification and there is the wire. 9 centimeters. That's not a dissectable margin. So we put in a second wire, leaving the first where it is because we were scared of withdrawing it and breaking it. So here we put in the second one, exactly where the calcs are. And by the time we take the fixation image, it's moved 4 centimeters further into the breast. Big problem in fatty breasts where there's no tissue to hold on to this. So these are some of the complications. We finally had to do a skin marking. And then there can be migration to extramammary sites, like here where it's gone into the chest. Then here it's actually reached the IVC. Then it can go into the neck muscles, the back. It's been known to go into the lungs. It's been known to reach the pericardium, but fortunately, these are all case reports. Now, the problem with wire localization, I'm going to take a couple of minutes extra, I'm sorry, that you have delayed surgery start times because it can be a difficult localization, as in the last case I showed, unexpected delays in the radiology department. When you have an early wire, the machine will invariably not boot in time. Unexpected, transport issues, the ward boy doesn't show up or something, and multiple patients all lined up for hook wires. So non-wire localization techniques have been developed, but they are not in significant use in India, mostly because our patients don't have significant insurance for these procedures. And this is a very expensive, capital intensive thing, most of them. Intraoperative ultrasound needs a lot of radiologist time, so not used very much. Skin marking is something that's not very accurate, although we do use it sometimes. Then we have injection of, radionuclide, which is radio-guided occult lesion localization. We just inject some technetium, but this has been abandoned world over because of inaccuracy. Then we have I-125 radioactive seeds. These are 5 millimeter seeds that are inserted into the axillary nodes and the lesions, very great for axilla especially. And you take out a much smaller area. Plus the surgeon has the happiness of being able to decide their own incisions instead of us deciding that they will go in from here. Similarly, you have MagSeed, which is a small steel clip. All of these are 5 millimeter to 1 centimeter. This is done, there's a fluctuating magnetic field and a introducer needle and a console that reads off. And then you have Savvy Scout, which is a radar thing with 2 antennae sticking out. And then we have an RFID tag. So in those, each RFID tag has a unique ID number, which makes it very nice and easy to localize. But again, there's a huge capital cost when you start. So basically, between wire localization and non-wire localization, non-wire is better for the surgeon. In fact, if you have a big onco setup coming, you should invest in one of these. But wire localization is something that is economically more feasible for India. So, and the big thing about non-wire localization is you can put these things in for up to 5 days to 7 days before the lesion needs to be operated. So we don't have the surgeons waiting for us on the morning of, surgery. So these are the main differences between wire and non-wire localization. And these are the ways that early cancer can be localized. Thank you.